Welcome everybody, it's Professor Spears and we're having another episode of Human Services in Northwest Indiana. And I'm very pleased to have as our guest Stephanie Harris. She's adjunct faculty at Valparaiso University in their music department, and she's also a licensed music therapist, and that is going to be the topic of the main part of our discussion today, is utilizing music therapy in a therapeutic setting. And the class that we are recording this in is my activity director certification course, and so much of the discussion will be related to long-term care settings, but we will dedicate a significant portion of our conversation to music therapy in other settings. So if you see us talking about that particular aspect a little more than you would expect in this podcast, that's exactly the reason why. So Stephanie, could you introduce yourself to us?
Sure. I'm a board certified music therapist. Indiana's not quite licensed yet. Some states do have licensure. Indiana does not at this point. But I am a board certified music therapist. I have been that for 20 years now. I did my undergraduate degree at Ohio University and my graduate degree in music therapy at St. Mary of the Woods College down near Terre Haute. I've worked at a practice behavior specialist of Indiana here in Valparaiso for my whole career. And at that job, I've primarily worked with individuals with autism and developmental disabilities across the lifespan. Some living in their family homes, some are living in a supported living setting, group home kind of settings, attending day programs and whatnot. I do have some experience working in long-term care through college and earlier on in my career. I worked in some memory care units and an assisted living unit. I worked both in the activities department and as an aide for them in that role. And like you said, I'm currently adjunct at Valpo for the music therapy department, and I also teach a course at St. Mary of the Woods in one of their distance programs as well.
Terrific. And I have to tell you that we've got such a shortage of music therapists in our area. So if any of you are musically inclined, that would be a wonderful thing to add on to your BSW or MSW. And my understanding...
I could talk a little bit about the education. Yeah, we
Please.
could definitely. So music therapy right now requires a pretty heavy music background for it. So the degree is made up of applied music courses, theory, learning to play instruments like guitar, piano, to support what we're doing in sessions, and then a heavy component in the psychology. But going on to do an equivalency, so folks can do an equivalency degree if they have a music ed degree or music performance degree, but there are some changes happening within that. It's been very heavily seated in Western music, right? Having that kind of privilege of having lessons growing up and having access to those types of things. And so programs are starting to open up a bit more to having folks who are musically inclined but maybe don't have the training to back up what they're doing.
Grandfathering people.
Yeah, so it used to be more of a conservatory setup where you had to meet all of the performance criteria to become a music therapist. And some schools are starting to loosen that a little bit because we have such a shortage, trying to help diversify and bring in more folks into the field. So there are a lot of folks out there who are very musically talented and would make great music therapists, but maybe have not had the access to that training and background. So there is some shift happening at some universities to try to move that direction.
And in some levels that might be you have to end that grandfathering at some point, but diversity is such an important issue in everything that we do as social workers, and being able to have music therapists who might not just be versed in Western, pop
training
or classical training could be very good.
Yeah.
Excellent. Well, thank you and welcome.
Thanks.
If you could explain for us the difference between somebody who comes in and they are a board-certified music therapist compared to somebody who is a well-intentioned volunteer.
Sure.
They come in, they perform, everybody has a wonderful time.
Yes.
How is that different from music therapy?
Well, I think it goes to the training that happens in the education. So, like I said, there's kind of those 3 tiers to what music therapists learn in their undergraduate degree programs. But part of those degree programs, we are a bachelor level entry, which is a bit of an oddity in a human service field right now, and does hurt us at times getting that kind of traction with funding sources and those types of the people that make big decisions at places that hire and whatnot.
Right.
But the other part of the undergraduate that kind of differs from other programs is that we have 120 hours of clinical practicums in the undergraduate degree, followed by a 1,200-hour internship and the board certification test before you can finish just your undergraduate degree in music therapy. So compare that to a master's, right? Like that's the level of clinical work that a lot of folks are getting by the time they're done with their master's degree.
Not a typical bachelor's
no, it's not
degree.
A typical bachelor's degree in a human service field. So, and there's been lots of back and forth about whether we should, lessen the undergrad, make it a master's level entry, diversify that track. But that clinical work is what really kind of starts to differentiate those practicums, getting face-to-face with individuals at different sites, really starts to kind of separate skills. And then there's the individualization of being able to have the music skills combined with the therapeutic skills that we learn from the psychology and those practicum to read what's happening with our clients, observe and see what's happening with them, and being able to adapt very rapidly in the moment what direction we might need to go with something. So while sitting and listening to music is very therapeutic for people, right? It has value for people. It brings them a lot of different emotions. The music therapist can adapt very quickly to what's happening, maybe understands if they're working with somebody with a mental health background, what some triggers might be with them. If there's addiction, what to kind of avoid and work with. Working with individuals with autism a lot, I'm very in tune to their cues for getting overstimulated or they're understimulated and how I might need to adapt what I'm doing in a session. And that all comes with the training and education that we have to back that up. So I would say that's probably the biggest differentiation. Yeah.
Could you give a scenario just to make it a little more tangible for people? Let's say that you were working with somebody who was in a skilled nursing facility and they had early to mid-stage Alzheimer's.
Sure.
How would that clinical and educational experience, what would lead you to make an adjustment, and what would the adjustment be?
Yeah, so if I were working with them, I would be observing, well, hopefully I would know them a little bit, right? I've observed them kind of in their general setting, so I kind of know what their baseline is, or I've worked with them enough to kind of know where they're at. But for that kind of level of dementia or Alzheimer's, we might be working on trying to keep some cognitive skills and speech or communication skills going. So If I were working with them playing a song, I could slow down or speed up. So this was one of the reasons I brought the guitar, right? Not to perform, but to demonstrate these kinds of things. So, oh, when the saints go marching in, oh, when the saints go marching in. And I might see them maybe starting to sing along with me, trying to maybe mouth the words, maybe they can't make full, but I might see them kind of start to do something along with me, but they're not going to be able to keep up at the tempo that I'm going, so I'm gonna, oh, how I want to be in that number. I lost my spot where I was. When the saints go marching in, oh, when the, and I might even use some anticipatory. So we talk a lot about psychology of music and how music is very innate in us. So we're going to use that, right? Like everybody wants to finish a phrase, or you don't want to be left without returning to that kind of tonic to, you know, whatever the key is that you're in. So that we use those things. That's part of our training to kind of feel those and navigate where to go with that.
Okay.
Yeah.
Great. Well, thank you.
Yeah.
And you have a beautiful voice.
Oh, well, thank you.
You're welcome.
I am a primary vocalist. That was my guitar. See, I lost my place mid song because I started talking in between. But
okay, and you mentioned bass lines.
Yeah.
Can you talk about your being that your primary focus of your education has been in music?
Mm-hmm.
What type of experience and training do you have in making a bass line and a treatment plan?
Yeah.
What would those look like?
So in our core music therapy, so right, those kind of 3 tiers of our education, the music therapy coursework is very heavily focused in that treatment process. Mm-hmm. So how do we assess where a client is, what their treatment goals are going to be, and how do we continue to make progress towards their goals. So goals in music therapy, we typically talk about them being non-musical, right? Kind of our elevator speech, because everybody asks what's music therapy, nobody understands. They want to, you know, so my elevator speech is I use music to work on non-musical goals like social skills, communication skills, motor skills. So that's kind of that. So our goals are very non-musical based. So my treatment plans have objectives like I'm working on a client filling in the end of a phrase. And that's a very measurable outcome for me. So I can take a little tally or however I want to take data in a session, and that gives me numbers at the end, and that gives me somewhere to look and move towards with them. And just sit back and evaluate if they're not making progress. Well, what am I doing as a therapist? What do I need to change? Or is that not an appropriate goal for them anymore because whatever condition they have or whatever, you know, that may be where they are and they're not going to improve anymore. I work with a lot of adults with developmental disabilities that we've gotten to the point where, you know, maintenance is kind of the goal sometimes, right? You don't, and so similarly with long-term care, maybe slowing down the regression of a disease might be the goal versus improving, but we can track things like non-musical, you know, those observable behaviors. And when we talk about behaviors, I think of anything that's a response to a stimuli. So anything that I can observe and see, I can kind of take some sort of data on. Yeah.
Well, you mentioned treatment for people with mental illnesses. What type of non-musical goals would you set for working with somebody who's got a chronic mental illness?
Yeah, so a lot of those are going to be focusing in on coping skills, using music maybe as a coping skill, maybe even helping them rediscover an instrument as a leisure skill for them to use as a way to pass time and not to, right? We may work on some social skills training with them, helping them to understand how that might, their mental illness might affect their social skills with other folks, and help them to do that. A lot of camaraderie within a social, a lot of behavioral health sites do a lot more group work, and so that might be just kind of creating that environment for folks to have a common shared space, but bringing the music into it can be a little less intimidating, might attract some folks that maybe have a harder time coming into a group setting, so there can be a little bit of a different take on how that works. I feel like songwriting and lyric analysis is a little bit more prevalent in that population, because generally cognitive skills are pretty on par, and they have a lot to say, they have a lot to contribute in that way. When we talk about some of those differences, again, I'm going to backtrack just a second, but some of the differences between music recreationally versus a music therapist, we have kind of 4 methods that we feel like our experiences fall into, and that's receptive, recreative, compositional, and improvisational. And so generally, sessions will kind of look, with any population really, will kind of be a mix of a couple or all of those to, continue to sustain attention for folks, make sure you're hitting different interests for different individuals and things like that. So the songwriting, improvisational work, the compositional and improvisationals is a little bit more prevalent in a mental health setting. Music therapists also, there are varying levels of advanced trainings and certifications, and a lot of folks who do work in mental health do often continue on and get master's degrees, because at the bachelor level we really feel like we can only be supportive and maybe not go into insights and reconstructive kind of things with individuals we're working with, be a little bit out of our scope of practice at that point. But a lot of music therapists that work in those settings often do go on and get kind of advanced licensure in social work or a psychologist, or additional certifications to kind of help them work through what can be, could be an intense situation with individuals in that setting.
Have you utilized music therapy with addictions?
I have not personally, but there are a lot of music therapists out there that are working with that. I actually just did a continuing ed with someone who's working down in a hospital system in Indianapolis, and I don't want to say it because I'm not sure. But she's doing some research actually with some different groups there, using some relaxation techniques that she's kind of developed over the years that she feels are really effective for those with addiction. And so there's some really cool work being done there, almost locally for us, which is really cool. Yeah.
So this is scientific and it's evidence-based.
It is. I feel like recently, music therapists, I think we really struggle with doing the clinical work and doing the research, right? So a lot of it happens at the academic levels and institutions, which I think is pretty common for most fields as well. And obviously COVID kind of put a halt to some of that for a couple of years. But yes, there's a pretty wide research base back. As a profession, we've been organized since the 40s when the first program popped up at University of Kansas. And so a lot of research did really come from kind of combining traditional psychologic principles and neuroscientists or musicians kind of working and realizing this. There was a lot of work in veterans hospitals. That's kind of where it took off as an organized profession, was during World War II. Veterans hospitals, a lot of nurses using music with veterans, and then people kind of taking notice and say, oh, there's something to this, and they started doing research. But there are a lot of neuroscientists out there that are studying this. If you look up online kind of imaging and music, MRIs, CAT scans, there's a lot of really fascinating study going on about what our brain does when it's listening to music, and you can kind of see the imaging. They've done some like live while they're doing brain surgery, and somebody's singing, or I think there's even one of somebody playing a violin while they're targeting different areas of his brain during surgery. And so there is a lot. There is our national association has worked closely with National Institute of Health, NIH, and there's some projects in the works to really amp up the research base that we have behind what we're doing. But there's also a lot of research out there of music therapists doing case studies and controlled studies of trying out different techniques and things too. So
I've seen studies where they've done functional MRIs.
Yeah.
And that, if you're not familiar with it, fMRI is where they're watching in real time, as Stephanie was saying, and you're in an MRI machine, and they can watch as the music's being played, or they've done a lot of research where they will talk to people or show them images that elicit different emotions. And they can watch where different areas of the brain, they inject contrast through an IV, and they can watch where the blood flow moves, because blood goes to the area of the brain that's being most stimulated at that time. And they can do diagnostic issues with that, and probably work on treatment plans based upon with what they find in the fMRIs. So I think it's really exciting.
It's really, it's fantastic to have that kind of research to back up. And I mean, that it speaks to music, even recreationally, being a really valid tool to use with individuals. And then the music therapist coming in with the therapeutic relationship and the treatment process behind it can kind of even edge that forward more for an individual that needs that type of support. So,
Okay, great. How do you know when you're being effective with a client?
Well, like I said, we do take data, so that is one piece of us watching and kind of seeing whether something's being effective with them or not. And I feel like we do a lot of qualitative observing as well. Is the person canceling appointments? Are they, how is their mood when they're with us, right? Those more, a little bit less tangible kinds of things that as a therapist we kind of clue us into what might be going on with an individual. Are they, at a long-term care setting, I think of an individual, just leaving the group and walking away. Is that happening every time? Maybe an individual session is more appropriate for them than a group session, so we kind of constantly do that kind of reevaluating with thinking through. And music may not be the right thing for everybody. Music can do harm, and that's another reason why music therapists are important in settings, even if support staff are helping to implement music in a setting. Having someone that can kind of check in on those types of things is really important. I kind of mentioned music triggering maybe a memory, or especially for addiction, those can trigger, or certain topics and songs can really have a harsh effect on us at times, and maybe it's not the right thing for everyone. I work with individuals with autism, and music is not the right fit for everyone because they can be very overstimulated, hypersensitive to sound. So it's not always the right thing. But I also work with an individual who's deaf and blind, and so you might not think that music would be appropriate for them, but it's very appropriate for them. They get a lot of sensory, they have heightened they need heightened sensory input because they're missing a couple of their senses. Mm-hmm. And so engaging in that sensory input is a really important part of their week. If they don't get it, then staff notices that they're not getting it. They're more antsy and seeking sensory stimulation in maybe not so great ways. So data is important, but I think there's also, we're working with humans, so we have to pay attention to what they're telling us too. So.
Right. And an important point that she brought up, she mentioned qualitative data. Mm-hmm. And I know that not everybody who's watching is familiar with the difference between qualitative and quantitative data. Yeah. Both are very important. Qualitative is what she's talking about is when you see in the moment the change in facial expression, somebody trying to leave a session or canceling. So these are direct observations that you're making, and it requires a certain amount of interpretation to take place by the therapist.
Much more subjective.
Yes.
So yeah.
And then the quantitative, that has where you do statistical analyses of things and you're operationalizing your variables, which means, and in class here we've recently been talking about SMART goals, and you need to make things measurable and countable. And that's the way in which, because if they only published in qualitative journals, they would still be struggling in getting, and it's very valuable data that you get, but insurance companies, they want to see the data.
I'd argue that the qualitative is much more effective at showing, especially in the human service field. I feel like that's generally, as a clinician, I feel like that's where it's at. But
those
everybody's, they still want
the numbers.
They still want the numbers.
Yes, they do.
Yeah, and you said SMART goal. That is exactly what we're using in our treatment planning. Is a similar, a version of that in our treatment plans, and taking data on those things. And we operationally define what we're looking at from a client to take that data on.
So it is very scientific. Mm-hmm. It's not just happy music time. We're all gonna sing, and it's not just a way to distract and help eat up time and keep people busy. It truly is a form of therapy, and it's. I've been approached, in my position, since we do so many internships, I've been approached by clinical supervisors in many different agencies saying, do you have somebody who's a certified music therapist? Where I've been looking for years for somebody and can't find them. And as I understand, the program at VU is fairly new.
Yeah, so that program, we just celebrated 5 years, but 4 years with students in the program. So we've just graduated our first 3 students over the last winter semester and spring semester, 3 students. So it is. I kind of told you when we spoke before this that when I moved here, there were no music therapists. There were only a couple kind of trying to work in the Chicago area. Really what brought most music therapists that work in this area here was that, or really across the state of Indiana, is that the Medicaid waiver program that works with individuals with autism and developmental disabilities began reimbursing for it. And so that is where most music therapists in this area work from, because the reimbursement is there